I think one more very important cause, and which I always emphasize, is herpetic endothelitis, which sometimes get reactivated in these cases. So always give a trial of systemic acyclovir and topical steroids if you have already ruled out Descemet's membrane detachment.
Dr. Somasheila.
All right. So, thank you to the organizers for inviting me, and thank you, Dr. Namta Sharma, for having me in this panel. I'm just going to go through a few interesting cases on dry eye disease and to see how all of us can gain some practical knowledge in this aspect. So, we know that dry eye affects almost all populations and it affects all aspects. That means of the quality of life, physical, social, psychological functioning, day-to-day activities that are limited, and even in the workplace productivity is limited. So it is a huge modern day epidemic in that way. So all you can have various kinds of dry eye, but I'm not going through the entire gamut, but I'm going to stick through in a few complicated cases of dry eye. So when I just flash these clinical pictures here, I can see three cornea surgeons sitting there with each other. So they would probably realize what's happening. So you can see that the picture on your very right hand side showing a very dry eye. The reflex is not clear, the slit lamp beam. And when you see, but your focus would probably be on the right eye, where you see that in the periphery, there looks like there's some infection perhaps or something like that. So, but when I tell, for example, Dr. Arundhati what this is, so she knows that this is a case of severe dry eye, maybe keratoconjunctivitis sicca. It's an aqueous tear deficiency dry eye, and she would immediately start looking at the patient systemically, whether the patient has Sjogren syndrome or anything like that. So this is a case of severe dry eye. Going back a little bit to the classification, so all of you know that we've heard about the DUE's classification, and you can divide them into aqueous tear deficiency dry eye, which is what I'm focusing mostly about. And that can have various causes for it. We'll not go detail for today, but just try to memorize that these are the various causes for aqueous deficient dry eye disease. So quickly through my cases. So the first case saw, but another patient who had Sjogren syndrome and presented with a corneal perforation. Right. And this is a 50-year-old female. She's known rheumatoid arthritis patient on oral tofacitinib, which is one of the newer agents. And she's already been on treatment for dry eye and just a 1 week history of sudden deterioration of vision in her right eye. What you see is that you see, of course, a corneal, almost like a perforation. The iris is plugging it here. But more importantly, you see this larger area. So the patient has had gradual increase in the dryness, perhaps an immunological mediated path as well. And then the iris is now plugging this area. So what do we do? So just step back. Remember that it's a patient. Look at this patient as a whole. Make sure that the other therapy of this patient is going on properly, that she's not defaulting. And as surgeons, we have to plug that perforation because it's an ocular emergency. With this patient, we did a Teenan's patch graft. She actually did very well about that. And we can also do a multi-layer amniotic, and we can also do uh, even a simple glue BCL. But this is the option we selected for this particular patient. So you can see at 3 months, there was more scarring and a sort of incorporation of the patch. So she could continue. She was continuing her medications well. She had defaulted in between. And the key points that the way we address this particular patient, I'm sorry, this patient we did an multi-layered amniotic membrane, not a Teenan's patch graft. So the key points here is as soon as we saw the patient when she came with the perforation, we escalated the therapy that was for the patient. So we gave her intravenous methylprednisolone. We escalated the oral steroids that she was on. And we to ensure that the patient was on adequate control of a systemic disease, whether we want to use J kinase inhibitors, as in this case, or any biological agents, or even the simple old-fashioned TMARDS also. And we have to monitor the other eye closely because you never know when the other eye can go downhill. So the tips here are, of course, manage the acute emergency in front of you, but also don't forget or don't neglect to manage the systemic part that the patient has. Second case I'm going to quickly show you is a patient again with rheumatoid arthritis. She's more complicated. She's had been with me for a while. So she has secondary Sjogren syndrome. She has scleritis. She also has PUK. So this is her right now. At this point in time, all the other things are mostly under control, but her vision is extremely poor. She just has counting finger right eye and left eye is also very poor because of both the corneal scarring as well as advanced cataract. She's of course on lubricants, topical steroid cyclosporin. She's also on these agents, mycophenolate mofetil and methotrexate for her systemic part. Most of these patients with Sjogren's syndrome, dry eye, we start them on autologous serum, and we also rehabilitate them with scleral contact lens for vision. In her case, since she was due for cataract surgery, I also planned to do punctal cautery at the time of cataract surgery. We can plan what we like to plan, but then the patient came back after 4 months, and this is like the previous presentation. She came back with very severe infection in the right eye, and in the left eye also she had microbial keratitis. So just like many of these patients with complex disease may have different infections, may have polymicrobial infection. So in the right eye, it was a fungal infection, and we had to soon do a therapeutic keratoplasty for her in the left eye. Luckily, it was a bacterial infection which slowly improved over time, but with dense vascularization to which seal the infection at least. The right eye, we did a graft. Again, she had a recurrence of infection in the graft. This time it was bacterial, and there was a poor prognosis. So this downhill story often happens in these patients with very severe dry eye if we don't catch them early or if they are unable to be compliant. It's not their fault. Sometimes they just cannot come for follow up and so on. So we're waiting on her left eye. We did a cataract. She had a total cataract. We did a cataract surgery for her, and she just has barely ambulatory vision. So I'm going to discuss one other case and then. So this is a simpler case. It's an elderly gentleman who has filamentary keratitis in both eyes, irritation since 1 month, and you can see these very large filaments. So this is not everything else systemic is normal for this patient. So this is not something very grave or very systemically driven. So it is an ocular condition due to poor blink. He also had early Parkinsonism. So these could be some of the conditions where there is a very sort of a flaccid upper lid which doesn't move much. And what we did is just immediately remove those filaments, placed a BCL and copious lubricants for this patient. It improved very well. They can be generated when there's friction also of the eyelid, when they squeeze their eyes a lot. And this is an abnormal mucus to aqueous ratio. So it creates, which is very conducive for the mucus to become filaments. So that was an easier way. And I will not go through in the interest of time. Instead, I'll just try to bring something. So, so at Chandilal's always try to bring in something new and different. So this August 2nd, we have a workshop on, it's called Scrape and Stain. So exactly as Pratmesh was talking about fungal infections, bacterial infections. So you get a chance to scrape and stain and see. So we have created a mock model where you don't know what the infection is. So you scrape it, you stain it, and you see and you tell us what it is. And along with that, we also have an extensive program which have all the stalwarts in from city, many of the stalwarts coming in, they'll be participating. One of the highlights is we have Dr. Savitri Sharma. The second sort of shameless plug-in I'm going to do is another program that we have coming up on September 6th. It is on AI and innovations in ophthalmology. We have national speakers who are experts in the subject, and this is going to be very new because there's a lot of AI. Everybody keeps saying AI. It'll be good for you to come and attend if you can, and also submit your innovations. So we have a section for competition, so you can submit your innovations if you have that. This is the Cornea team at SSCI, and our microbiologist, without whom we can't do what we do. Thank you very much.